Hi everyone, it's a huge honor for me today for our next straight talk with Dr. Christian Leonardt, who has actually the honor, and I'm really honored to have him for the course 4 in our academy on the 27th, 28th, and 29th of June this year. And it's a huge honor because I don't know any dentist who knows as much as Christian does. So, and he comes to us because he has a huge knowledge on orthodontics, on restorative, and he knows the limitations of dentists, what they have. And that's why he did so much more education on that to learn even more in orthodontics and everything else around it. So I'm very honored to have you here, Christian. So please tell us, what is this course about and what do you think these dentists out there need to know and take away from your course in June?
So first of all, Stefan, thank you for the invitation to your practice and your courses. Um, it's very important to know where my journey is coming from. So I started as a prosthodontist and soon got the limitation of every process what we have. So that's the reason why my ortho journey started. And as I began to learn ortho from all the specialists all over the world, from perspective of airway, dentofacial function, I recognized that there is so much more to learn in that. And the difference in our course to other courses is that we learn ortho from a totally different perspective, so that we are able to plan ortho from a way which is possible to treat restorative cases like as you plan your ortho cases. The only thing what you cannot do with ortho is changing the morphology. So when we started ortho, there was a huge learning process in that. And this learning process in the last 5, 6, 7 years is what I melted down to that course. And what I bring to you is a learning curve, which is more than every course I ever had. So we learned that this way of ortho planning is so much more important in different perspectives, not only looking at models. We look at the face, we look at the airway, and plan at the last point, the models or the teeth in the face. So when we can go, Stefan, I prepared a case for you and for all of you.
At this point, I would like to ask you a question. Where do you think most orthodontists or dentists actually fail right now? Why are there so many cases that might not go according to plan? What do you think is the main reason for that?
You know, the problem is that we learn from a traditional way of ortho planning that we look, for example, we look at models in MIP bite. So this bite is a real big problem because when we change the position of teeth, we learn from the prosto perspective that we have to do a bite in centric relation before, because we move all teeth. And so we could not expect that the patient in his MIP bite is in a correct way. So what we see in the course is that when we plan from a centric relation bite, we have more predictability and we are more precise and we reduce the problems and we have less refinements in our cases. So this is a real big thing because we all had the problems when we planned the ortho cases. Then the patient went through and we looked at the aligners, all teeth are fitting well in the aligners, and we looked at the bite and there was suddenly a not planned posterior open bite. So what happened? So in this course, we learn, for example, what is a constricted chewing bite where the MIP bite is behind the normal bite. So what does it cause to have compression? And then when patients were released to that bite with the aligners, what the reason is that they have an posterior open bite, that they only have contacts in the front. So another thing is what we learn is even for recessions. Recessions are mostly the symptom of every problem. So to know the reason or the cause is much more important than to see what's going on. Because what we want to happen for our patient is that we reduce the risk and have a better prognosis. And to treat a patient right, it's so important to know the cause for that symptom, not only to know the symptom.
And where do you see AI actually plays a big role in that? Because obviously you all think that AI helps us in diagnostics and all the rest of it in dentistry. But I think from a reality point of view, like the first clean check of some of these companies is generated by AI technology. And 70% of these clean checks are being accepted on the first one. So how do you see that? In the danger of predictability and what you just talked about?
So this is a good question, Stefan. AI produces a lot of information how we can bring a tooth from position one to two. But the problem in that situation is that we have biology. And to understand biology, to understand what the periodontal ligament does, to understand what the bone is doing, to understand where are the limitation, this is not in the AI software. So we have to know exactly where to place teeth and how to bring that into position. A good example for all orthodontists is to have a class 2-2. And when you look at the lower front, you always see the compensation and adaptation mechanism. So when we see this, the front is always posterior. It's a retroinclined situation. And when we plan this with AI would intrude it and bring it forward. But the real big problem is that we have a bone which has a hard bone around and a soft spongeous bone inside. So when we want to intrude this root from a biomechanical point of view, we see that the coronal part of this tooth is in the compact hard bone and the apical part of the tooth is in the compact hard bone. So when AI plans that for us, with the intrusion, we have no chance because the whole tooth is moving against this hard bone. So instead of that, for an easy example, we have to upright the situation first to talk the root inside of the sponge's bone and then doing the intrusion process. So this is one easy example where you can define what AI does not do for us. So this is something what we learn in this course to understand, and we have a lot of more cases like that, which is easy to understand, but we have to know it.
And how about you talked about the sagittal dimension with class 2 div 2? How about the transverse dimension of cases where, I mean, again, AI but is very good in expanding a cartoon, the transverse dimension of that clean check. But what is the reality actually doing?
You know, AI does not know something about your bone. It does not know about your crestal type. It does not know about the phenotype of your mucosa or gingiva. So what we have to learn is the limitation of every process, even the already happened compensation and adaptation mechanism. So when we want to expand an upper jaw, we have exactly to know the limitation. And we have a lot of science in that. And this science is already there. And when we want to expand the jaw with aligners, even the upper jaw, there's a limitation of 1 to 2 millimeters, maximum 2.5. The other mechanisms are dental alveolar mechanisms. So this is where we have to bring the force to the dental alveolar surrounding of our teeth. And when we have patient, we plan from an airway perspective. So what literature says is when we are under 37 or 38 millimeters, we have a problem because the risk for obstructive sleep apnea is going through the floor. So the problem in that is knowing exactly what to do and not only let the AI software do this for you, because it's there's something where all people say you cannot bring teeth outside of the bone. The reality is we can, but we shouldn't. So we have to know exactly from our perspective of the X-rays where to place the teeth, where we should go, and to do the backward planning to that. So we have to find out which is the best movement, which is the best device, which devices could be combined even from dental, that means aligners, from dental alveolar, is for example SFOT, or transversal expansion from a skeletal point of view from the midline with a MAPI.
And in the course, will you also talk about movements that are less predictable with the liners and what you will do to support these movements? Let's think about extrusion or torque movements or things that are clearly by research not very predictable with lines. Will you go through also in the course how to make these things more predictable?
Yeah, we go all through the biomechanical processes. We bring that literature, what is already existing, the new literature, is bringing that all to the courses. And we will define it for a phenotype-driven ortho. We will define it from a biomechanical-driven ortho, and we combine it. And Stefan, you know the pyramid. We go through all the processes in our treatment planning. The first and important step is the airway. Then we go into dental facial in every case. Then the next step is the function. Then going into biomechanic, and the last step is the perio. So we go all through, we do a risk assessment for every step, and we define what to do and not to do, or what we could do to improve the prognosis, or what is possible to do.
And would you say the course is for people who have a lot of experience in the liners, or would you say the course is for beginners, or what would you say is the right participants for this course? Because obviously your level is really high, and we might need a certain requirement of participants to have that they have maybe failed in some of these cases already, and they have these questions they want to ask you. What would you recommend? What would you say to them?
I would say to them it's for both, because I tell you what, all the knowledge I had and what I learned in dental school, what I had from our master courses, was that I had to unlearn. And the most important thing is that we start from a total different point of view to plan all the cases. It's a new philosophy to bring cases and to define where you should look at it first. And it's not the teeth. We start from a different point. We start from the face, we start from the airway, we look at the function, and we end in the teeth. So it's a different total model, and I would say it's for everyone. So it's better to have a good combination of all experts, even when they come from a prosto, so that this is a new topic in prosto that we learn. It's the best thing, because ortho for us is now the superpower of the prostodontist, and we can plan this. So both sides are possible.
I liked it what you just said that ortho is the superpower of an orthodontist. I thought basically it's for all of these orthodontists out there who restore teeth, and they might work already with someone together who doesn't do it maybe the way they wanted to do, or they don't have anyone and they have the need to do it themselves. So it's basically for all of these restorative dentists who treat these teeth.
Right, right, right. They drill them down even if they are in the wrong position, and this couldn't be the future. So all knowledge which is in prosto and all knowledge which is in ortho is combined in that course.
That's so, but of course, it's also for orthodontists like myself. I went to John Coy's once and learned how prosthodontists think. Even I'm an orthodontist because as an orthodontist, if you want to work with one of these dentists together, you need to actually speak their language. So it's also for these specialist orthodontists who might feel like there's nothing left of this business because all the dentists taking over the world with aligners. So it's also for these orthodontists who to make them aware you need to be good, you need to speak the language of a dentist so that you can talk, do these things together. Because I believe, Christian, if you would have a really good orthodontist by or in your team, you would just think about restoring them. Am I correct to say that?
I would. So, I would. The problem is what we have in Germany or in Europe or in the US is that we always think of two worlds. And we are all dentists and we should think to combine both knowledges and to make the best out of it. A good thing what you mentioned was that even we have not the same words or not the same interpretation of the words. When we talk from an overjet, from a prosthodontic point of view, we always take the buccal surface of the lower front tooth to the palatal surface of the upper front tooth. When we say there's no overjet or zero overjet, we mean from a prosthodontic point of view that we have a contact situation, which is the posterior bite. So when we talk from an ortho point of view, we all know that zero overbite means that you have had bite there. So we should think about having a new wording for that or bringing both together. And so when this is there, it's a lot more easy to bring all technicians together, because what we do at our patients is the things what we do, but we have a team behind us who should understand what we are thinking. And the most important thing in our practices is that we duplicate ourselves, so that we duplicate our knowledge to our technicians, to our staff members, to all the people who work in the aligner companies, to the foreign technicians, and even to the patients. And so it's so useful to do that step in the next time.
Yeah, I understand. So let me show us some cases, Christian.
Oh yeah, we start with one case. I will now give you access to that case. I love this case because in that case, a lot of things are combined from that. And it's a dental facial case. And when we see that patient, we have a problemist here because we have an anterior open bite, we have crowded teeth, we have a collapse of posterior teeth. The reason for that we can talk about later. We have nearly the beginning of black triangles, we have hanging posterior corridors, and the patient has a thin phenotype and some recession on posteriors, even on the front teeth. And for the history of this patient, she is 28 years to that moment. She came to my office to have a second opinion to what it should be treated or not. And she was a different orthodontist before. And they said, okay, this is an easy treatment. We only can bring the front teeth together. So by extrusion of the upper and extrusion of the lower, a little bit retro inclination of the lowers. This is a good thing to do. So when I was looking at her and I would see her from this extraoral point of view, we have different more problems. We have a gummy smile, we have a higher lip mobility, we have asymmetric arch forms, we have asymmetric hanging posterior corridors, we have a non-competent lip closure, and even that phenotype, and we see the recession from an extraoral point of view. So what I told you before is we created a new treatment protocol for prosto and for ortho. And we start at lowest point from the airway, where all the airway concerns are in, from structure, function, and behavior. Then we go into dentofacial, where we exactly have to know where to place our teeth in the face. Then we are going into function, then into biomechanics, and then into perio. So what about the airway in this case? And you see this animation of the CBCT of the patient. We have the structure, which is in high palate in this situation. That means that the reason for this is highly to a mouth breathing situation from an epigenetic point of view. We have a narrow arch with 35 millimeters. We should achieve always between what I said, between 37 or 38. Then we have an anterior tongue thrust and mid-tongue restriction, or the old word for that is a posterior tongue tie. And the patient already is a myofunctional training. So that is what she knew, that she has a wrong swallowing pattern. So we plan from a dentofacial point of view from an extraoral. So we have exactly protocols how to take the photos. This is what we learn in the course. How to bring that to the digital smile design and to plan where the teeth have to be in the face. So in this situation, we see that these crowded teeth have a little bit of candid maxilla, and we want have the posterior corridors come up. So what we don't want to do is what the recommendations of the orthodontist were, that we extrude the front teeth because, you know, of the extraoral risk management, we have already existing gummy smile. And so this is something what we should not achieve. We want to bring all teeth in the maxilla up, even the posterior corridors. So in the end, we have even to know what is a gummy smile and what are the reasons for that gummy smile. The reasons for a gummy smile are 4 points. We could have an altered passive eruption. This isn't the case in that situation. We could have, like it is in class 2 div 2, dentoalveolar extrusion. We don't have this, but we have a high lip length, a low lip length, and a high lip dynamic. And we even have VME, and that's from what we know from literature, is that the cause highly connected to a mouth breathing situation. So when we plan it from the AP situation, we want that all posteriors come up, and the distance is not that few. So there are 4 millimeters to bring those teeth up, and this will cause what? It will cause loss of vertical oral dimension. And what causes when we lose vertical oral dimension by the intrusion of the posteriors? We have counterclockwise rotation of the mandible. And this counterclockwise rotation of the mandible has a problem because we lose overjet, because the whole situation is on a rotation movement. And what we don't want to have is wrong context on anterior teeth. So we want that all contacts in MIP are on in the posterior teeth. So patients do what with the teeth? They chew, they speak, and they swallow. And so the reason for that is that we don't want to have a more difficult situation in the end when we intrude those posteriors and the patient is only on front teeth. So in this situation, we have to know and we learn how to plan it from a functional point of view, where are my teeth after the treatment? So in this situation, what we have here is the mocha. This is in the course. We learn how to plan from a digital way. We learn how to plan from an analog way. And so what we know here is exactly where to place our teeth. So we know the airway perspective. We know the dentofacial perspective. We now know the functional perspective. And then we have to know how to do that. And this massive intrusion by 3.5 to 4 millimeters is only possible when we have a skeletal anchorage. So we learn in that course how to place TADs everywhere in the jaw. And it is not a complicated treatment. So in this case, we inserted two TADs on both sides, one on the palate, one on the buccal. And what the patient has to do is that he puts in his aligners, takes the elastics, puts it over the elastics, and this is the force on a vertical movement. And then we can move the teeth on the arch with the aligners. So what we have in the end is a good way of movement, a good way of predictability. We have even the small phenotype, and that's what we see then, that we have the possibility to bring that to an extraoral point of view. We know exactly where are my teeth afterwards. We know exactly what is the power of the PDL. And then we plan how to bring the teeth exactly in the right position from a perio point of view, or how to have more predictability from the way we plan it with the soft tissue, the surroundings, the movements, even if it's necessary before or after the treatment. Good. Steffen, wir machen hier kurz eine Pause, weil ich muss meinen Akku anschließen.
Ja, ja, mach mal.
Ja? Der ging aber jetzt schnell, ja. Steffen, wie lange wollen wir heute machen?
Bitte?
Wie lange machen wir? Schon noch ein bisschen,
Ja,
oder?
ich wollte auch mal ein paar Fragen haben.
Okay, warte. Ich weiß nicht, wo meine die Jungs an meine Tasche liegen. Ich bin vorhin das Rad gekommen. So. War es zu lang, die Fallpräsentation?
Nee, nee, überhaupt nicht. Jetzt machen wir die Stop Sharing, dann kann man noch mal Fragen stellen.
So. Warte mal ganz kurz. Ich bereite schon mal kurz den nächsten. Wollen wir noch einen Fall machen oder wollen wir später
Nee,
irgendwann
nee,
noch?
ich würde keinen Fall machen.
Keinen mehr, oder?
Nee, ja, ich kann da ja aufhören. Das ist super. Was ich mir jetzt überlegt habe, war, let's see another one.
Oh, I prepared for us an airway
So
case.
actually now we have seen our case, which actually quite often I think is a big demand where molars are being intruded. And as we know by literature, intrusion is a very predictable movement. with aligners, especially in support with mini screws and tats and elastics. So I'm really interested to see the transverse correction. And I know you do the dome technique, so it would be very nice to see what is it.
Yeah. The difference between what we saw in the last case was that we had a transversal need for expansion for 2 to 3 millimeters, which is the maximum of what we can bring teeth or do from the PDL to the dental alveolar part. So when there's a need for more, we want to achieve 37 to 38 millimeters, and we have patients who have an intermolar distance of 30 or less. We cannot do this only with aligners. We need additional devices. And I prepared a case for you. And that's what we learn in the course. For example, this one. This is typical. So when we see the patient came to my office and said that she has a permanent drowsiness, she is being referred from a speech therapist to my practice, and she even wants to improve her smile. So when we see her, and that's what we learn, and that's what I learned, is that this whole face tells us a story. And when we look at the eyes, you see the spots under her eyes, that you see a little bit this bone shining through the tissue. That means that she has no hard night. That means she's really tired. When we're looking at the proportion of the face, we see that this long face here, and we see even the small nose there. And when we're looking at the lower third of the face, we see here these VME again. We see the gummy smile. We see small lips, dry lips that comes from a mouth breathing situation. And even those spots, all those red spots around of the lips, that seems to be a little bit too dry. When we go in the case, we see what's going on. When she's trying to close her mouth, she has to bring so much pressure to all the muscles in her chin, and she has a really no competent lip closure. When she's speaking to me, and that's what we see here, she's narrow. She's really narrow. And you see the lips, they're without any tone, and this is a typical mouth breathing situation. When I was asking her, and we learned even in the course how to do a sleep assessment in our patients to know exactly from anamnesis to the real sleep assessment with a sleep device, and what we have from the data then. What we see here, the tongue position on the central picture. So this patient has a low tongue posture. So the problem is that this low tongue posture has no possibility to bring forces to the upper jaw. And this situation brought over time over time, brought so much force to the upper jaw, and all the teeth collapsed. So this jaw had never a chance to grow in the right way. So what then happened is, when you see the smile picture, this whole jaw came forward. So we have a narrow jaw which come forward, and we see the situation, even from an epigenetic point of view, this VME. So when we see the patient from a lateral point of view, this tells not a story, this tells a whole book. You see this profile of the face, these muscles around of the chin, the nose, and all or a few people say that we don't need cephalometric analysis. I would say we need it in that situation, because we have to know exactly where are the problems in our face. If we have a deficient upper jaw or lower jaw, how much we can bring it forward, which are the right data, or which is the right data for the airway. And we learn new things like a PVA line, where the maxilla is to the airway. And so we learn from literature, we bring that on. When we see intraorally, we even see here big problems because we see no recessions. But look at the tissue. This tissue even tells us that we see the teeth shining through the tissue. So it's a really thin phenotype. And the problem in that is when the patient is still collapsing on the posterior and the front teeth are crowding, the teeth are moving outside of the envelope of the bone. And so the risk in that situation is very high and the prognosis is really bad. So how to improve that? So think of what we were talking about, Stefan. Think of that, what we were talking about 30 minutes ago. We learn now to plan from an extra early point of view. And at the last point, we look at the teeth. Because when you plan this case from a normal point of view, we learned it in dental school, it's a total different thing because this patient is nearly in the class 1. So in this situation, we see even those angulation of the teeth, and even on posterior, this negative crown talk to the oral side, we see the talk of the roots to the outside. Even from that side, both sides are the same. We learn then what is going on with function. In this situation, we learn how the patient is chewing. We learn if it's a vertical chewer or a horizontal chewer. We need exactly how to place the teeth. Even when we do the transversal expansion, we learn what is necessary, which contexts are necessary. And we even learn a little bit back from the airway perspective, what we can do for the airway to this patient. We can work in a transversal expansion to the structure. What about the function? What should the tongue do? What should all the experts around us do? The speech therapist, the ENT, all the people. What is going on with the head posture of this patient? Is this a problem in that situation where the prognosis for neck problems or posture problems is a difficult thing? So when we see, and this was amazing because I looked at in this situation, and she told me that she already was at the orthodontist because I saw the retainer in that moment. And I said, oh, and I asked her, oh, how long has it been when you were the orthodontist? And she said, 5 years ago. So I was asking her, is this a relapse or what is this? And she said, no, the teeth are nearly in the perfect position. We'll see a little bit crowding in the front, but she cannot breathe correctly through her nose. And what I told you, this 38 millimeters, and what we have in our practice, and this is a cool thing, our cotton rolls are 38 millimeters. So we have now a new device how to check if patients have a good transversal or intermolar distance. And so I was thinking, wow, how cool is that? I can check every patient with a cotton roll. But I do it a little bit better, and this is even what we learn. We learn how to do that with our measurements, how to do it digitally. And here we see this patient has 28 millimeters. So a whole centimeter, 10 millimeters are missing to be in an acceptable transversal width, where the literature says there is a less risk for obstructive sleep apnea. So what we do here is we measured the airway. We saw that even that here we have negative PVA. So we want to achieve 97 millimeters from the PVA to the A point. but even here she's worse. And then we can bring that to the face, especially know what is changing in the soft tissue from the facial point of view. And then we bring that all together. We see the scanning of our models. We know how to define it, how to see all the problems there. And we go into the X-rays, we go into our airway analysis from a CBCT, and we have cool new gadgets in our CBTC softwares. I think a lot of programs already in the industry have it. So we can define it by only having 2 points from the nasopharynx to the hypopharynx. And this is what is telling us. And a cool thing here is what's going on is that we're talking about airway problems. But what we should know is that patients can compensate and adapt. And what she's doing here is that she is compensating and adapting a lot. And so we even have the patient who's telling us she cannot breathe, she's already snoring, and we see this. So the interpretation of that is a little bit difficult, but we have to know that patients have tongue postures where they can breathe. And what she told me in that situation, that she was even breathing to her mouth when we did the CBCT. So that's our whole assessment, what we learn from an extraoral point of view, from an intraoral point of view, from the X-rays. But to come to the execution is that we place TATs in the palate, all guided. We have a guide from the outside because the new dome therapy, which I created together with Claudia Pinter, is that we have the possibility now to know from a digital point of view or to match the CBCT and the STL and to know exactly where we can place the cut to the bone without cutting to the roots. And the idea behind was that the new dome therapy, you see here, it's the inserted splint. And the new dome therapy is a minimal invasive approach to have a better nasal breathing, to have a more predictable transversal expansion, and to have no dental alveolar compensation. I would say we decompensated to have the roots in a better inclination, to have it in a better position, to have less risk for future recessions and for better prognosis. So what we do is only 3 small incisions on each side. And these small incisions have let us bring a piezo into the sinus. So we go into that and we talk the piezo from the inside of the sinus to the bone. We exactly know that we are above the roots and we go directly from the pterygoid to the pterygoid on both sides. Then this is how the patient is done after 30 minutes. And the nice thing to the older version of the dome therapy is that this patient can go into a restaurant in the evening time. So we need no antibiotics. We need 1 or 2 ibuprofen for the patient, and we can directly go in with the device, even with inserted aligners, because this is a new expansion protocol. The problem is when we only do the expansion with a MAPI inside, we create those diastemas. And I don't really like those diastemas because I get in trouble when I lose papillas. And I don't want to lose them because the recreation of papillas is not an easy situation because when we have soft tissue in between both sides of the maxilla, there are a lot of literature where it's defined how to create a papilla, and I don't want to change the morphology because I did an expansion. So what the patient has to do is to have the small key, then bring it up. And what we can do to the midline is that we even cut this when patients are older than 35 or 40, and even do cuts on the pedal side. So this is the procedure. And now we did a lot of cases in that, and I can show a lot of final results, but this is the answer to the problem when we have a deficiency in the transversal width.
Wow, wow, wow. What a case. I mean, expanding the arches with the aligners, some people find that difficult, but then combining it with the dome technique and surgical approaches is for some of you maybe mind-blowing. Some of you might be scared actually when looking at that case, what Christian is doing there. So, Christian, just to summarize, what is your main goal for the course, what these students should learn?
The main goal is that we learn the new protocol of treating patients right from a general point of view. So we have all aspects of dentistry inside, and the main goal is to understand what or how we should plan patients' treatments and nothing more.
But would you also say they will also learn where their limitations are much more than they maybe ever did before?
Yeah, we go beyond it. So we have every kind of literature in that, and we do not do rocket science there. We learn how to do that and to create such amazing situations and such amazing cases. Yeah.
Or would you say that with the diagnostic they are getting from the course, they will also see if they themselves will be able to treat that with the knowledge they have in that moment, or that they can make a decision, is that a case I actually should start treating at all, or should I straight away refer to someone they feel more competent in treating that case?
So we get a stepwise protocol, and everyone could put himself into the protocol and to realize where experts or specialists around are needed and where to look to them or how to ask them or how to prepare the case for them. This is so important. And then where you see exactly where a case has a high difficulty or which is low difficulty in that situation.
Yeah, I think this is super important also for the course. The course will show you what can be done, but also it will show you what you should do to achieve that. And for some, it might be that you're confident in doing the dome technique. For some of you might not be as confident, and then you need to reach out to people who may be able to do it. But it's about the right thing to do. I think that is the most important thing, to be safe, to do the right thing for the patient, and not only just from a teeth perspective, also from a breathing perspective, airway perspective, health perspective, because at the end of the day, we need to do something good for the health of that patient as well.
Right. So I'm happy to see you. I will be glad if we have the first course or we plan different courses then. And yes, it's an honor to have you all.
Yeah, I can't wait, honestly. Thank you so much for your time, Christian.
Bye. Have a good night.